Hey, welcome to my educational channel. I'm Jibi, an autonomous nurse practitioner currently practicing in Florida. Today's video of insulin management in type 2 diabetes is intended as an educational practice review for primary care nurse practitioners or nurse practitioner students or any healthcare students. About significance of this topic of type 2 diabetes and insulin, as we all know, globally it's estimated 463 million people have diabetes. Out of that, about half of them, 150 to 200 million of them, depend on insulin. The demand for insulin is expected to increase by more than 20% from 2018 to 2030. In United States, per estimate, 8.4 million people used insulin, which is 11% of the population. To about 20,000 people with type 1 diabetes use insulin. 348,000 people with type 2 diabetes use insulin. So it's very important that the providers should know about diabetes, type 2 diabetes, and insulin significance in type 2 diabetes. And barriers to insulin use are fear of hypoglycemia, injections is time consuming, interference with physical activity, or lack of knowledge of adequate injection instructions, injection site reactions, or social factors, or lack of family support. So today's video, we will discuss mainly, as it is for a nurse practitioner review, not much about type 2 diabetes, but about the insulin, about insulin secretion and difference in type 1 and type 2 diabetes in human body. Number 2, insulin types, mechanism and the difference in actions and the different modes of delivery. Number 3, how providers can educate patients how to use insulin from vials or pens or different delivery methods, and about signs of hypoglycemia. Let us discuss about insulin function and insulin production difference in type 1 diabetes and type 2 diabetes. As all we know, insulin is a hormone produced by beta cells in pancreas, which regulates metabolism of carbohydrates, fats and proteins, so thereby the absorption of the glucose from blood into the cells of liver, fat and skeletal muscles. So it is released throughout the day at a low level, and it maintains the resting blood glucose level at a healthy range between eating and during the night. It allows the constant low level uptake of glucose into the cells for cellular processes. So what happens when you eat a meal? The beta cells release insulin in a biphasic pattern. First, there is rapid release, the stored insulin from inside the cell. Secondly, there will be increase in insulin synthesis for a smaller but consistent second phase release. This underlying mechanism explains why we administer insulin during the night and prior breakfast, lunch and dinner. As you see in the top picture, type 1 diabetes mechanism, the pancreas is because of idiopathic or autoimmune cause, there is none or little insulin is produced. So there is, because of the decreased insulin, there will be increased glucose in the blood, and the muscle is unable to use glucose due to the low insulin. The same with the liver, is not able to perceive the glucose, so they are going to produce more glucose by glycogenolysis, and as you see in the picture, glycogen and protein breakdown causing ketoacidosis. Next is a second picture. You see the type 2 diabetes mechanism. Type 2 diabetes is a metabolic disorder in which body's response to insulin is reduced, called insulin resistance. As you see in the picture, you can see that the sensitivity to insulin receptor is reduced and the glucose cannot enter the cell. So the insulin production is gradually increased by the pancreatic cells to try to counteract this insulin resistance, but over time there is a progressive decrease in insulin production and also decrease the secretion of the insulin levels. This combination of the insulin resistance and impaired insulin secretion results in hypoglycemia and type 2 diabetes. And as we all know, type 2 diabetes is more common than type 1 diabetes, making up over 90% of the diabetes diagnosis. Next is insulin type and action. As you can see in the picture, there are 5 types of insulin: rapid acting insulin, short acting insulin, intermediate acting insulin, combination insulin, and long acting insulin. And you can see the graph of their duration of action. And about the rapid acting insulin, the insulin Lispro is Humalog has been approved for pre-meal and post-meal. The onset is 15 minutes to 30 minutes, peak action is 30 to 90 minutes, and duration is less than 5 hours. And insulin aspart or Novolog, or another name is Fiasp, onset is 15 to 30 minutes, 13 to 90 minutes, and 3 to 5 hours. And insulin glulicin, Afitra, 15 to 30 minutes, 30 to 90 minutes, and 3 to 4 hours. You can see the graph for the duration of the action, the top one. And about insulin is commercially available in concentration of 100 or 500 units per ml. U500 is used in rare occasions when need larger doses. U100 is a common one. And for pre-filled pens, U200, U100, U300 is also available. Next is short-acting insulin or insulin regular or Humulin R or Novolin R. For new nurse practitioners who doesn't have much nursing experience, not get confused with rapid insulin. This is regular insulin, even though it's Humulin R or Novolin R. The onset of action is a half hour to 1 hour, and peak action 2.5 to 5 hours, and the duration of the action is 5 to 8 hours. And as you can see the graph also on the right side. And this is used primarily in case of marked insulin resistance, and also it's injected pre-meal to blunt the postprandial rise in glucose levels. And this is one of the insulin which you can be used intravenously. Next is intermediate acting insulin NPH. Humulin N and Novolin N are the examples. The onset is 1 to 2 hours. Peak action is 4 to 12 hours, and the duration is 12 to 16 hours. You can see on the right side the green graph, the duration is 12 to 16 hours. This insulin is mainly used in type 1 diabetes, but it can be used in type 2 when others are not effective. It's used twice daily, like before breakfast and dinner, so it can cover the in between meals or during the fasting time. Next is combination insulin. What is the advantage of combination insulin? The patient does not have to draw from 2 type of insulin, and it's already pre-mixed. Plus, get the advantage of both insulin. For example, if you're getting the first one, insulin aspart plus insulin deglutec, you get the benefits of the rapid acting and the long acting. The duration of action is, most of them are 14 to 24, ranging from 14 to 24. The onset is 15 to 30 minutes, and the peak is from 2 to 4 hours, except the insulin Lispro protamine plus insulin Lispro Humalog mix 75-25. It is 1 to 6.5 hours. So it's kind of little bit more than the others. So other examples are NPH plus R, which is Humulin 70-30 and Novolin 70-30. When you hear Humulin or Novolin, you know that is intermediate acting insulin combination. Then Lispoprotamine plus Lispro, which is Humalog 75-25, Humalog 50-50. So when you hear Humalog or Novolog, you know that has the rapid acting is there. And then aspart protamine or insulin aspart, it's Novolog mix 70-30. So what is NPH? Is the expansion is neutral protamine hagidon. It was discovered in 1936. The effects of the sub-Q insulin can be prolonged by the addition of the protamine. Next is long-acting insulins. Examples are insulin deglutec or Tresiba, insulin detamir or Levemir, insulin glargine or Lantus or Toujeo. These long-acting insulins provide a basal coverage and then basal insulins are suppress the hepatic gluconeogenesis, which is the formation of the glucose in the liver. They prevent the glucose from rising during the fasting state in insulin deficient patients. Pharmacology of insulin detamir is an insulin analog coupled to an 18-chain fatty acid that binds to the albumin in subcutaneous tissue. Why there is a delay in absorption and a prolonged duration of action, which is good mechanism of action in detamir. All insulins except insulin glargine or lantus are formulated to a neutral pH. Then insulin glargine, detamir or glutec cannot be mixed with the other insulin. About insulin detamir or levemir, the onset of action is 1 to 2 hours, and then the peak action is 6 to 8 hours, and the duration is 24 hours. And then insulin glargine or lantus, the onset of action is 3 to 6 hours, and the duration of action is 20 to 26 hours. You can see on the right side the blue graph. It's the duration of the action is almost like 24 hours. Then comes the next in the long-acting insulin, Tresiba and Toujeo. Tresiba or insulin deglutec is available in vial or pre-filled pen U100, U200. And then the action, as you can see, the onset is 30 to 90 minutes, which is very advantageous than the other insulins, long-acting. It's already starting in 30 minutes, and the duration of action is 42 hours, which is longer than the levemir and the lantus, which helps the patients to have it once a day. And also if they are late for their scheduled time because of the prolonged action, you can be a little bit late. That is the advantage of it. And then comes Toujeo. It's available in U300, and the onset of action is 1 to 2 hours, which is better than levemir and lantus. And then the duration of action is a little bit higher than the levemir and lantus, which is 36 hours. And then, but by seeing the U300, don't think that when we are switching from lantus to Toujeo, the patient may only need lower doses. That's not the case. When switching from lantus to Toujeo requires a higher dose until we stabilize the patient, or it can vary depending on the patient. Next, we can discuss about how to calculate insulin dose in diabetic patients. Let's discuss about the guidelines from American Clinical Endocrinology Association. So as you see in the right side of the picture, start basal, which is long-acting insulin. So if the A1C is less than 8%, the total daily dose, we calculate it by 0.1 to 0.2 units per kilogram. And if the A1C is greater than 8%, total daily dose 0.2 to 0.3 units per kilogram. So for example, if the patient is body weight is 60 kg, so 0.2 units will be 12 units per day, or 0.3 units per kilogram, it's 18 units per day. So if the insulin and also then insulin titration every 2 to 3 days to reach the glycemic goal of the fasting blood sugar. And then the fixed regimen increase the total daily dose by 2 units. But if we are following adjustable regimen, the fasting blood sugar, if greater than 180, add 20% of total daily dose. Or if it is 140 to 180, add 10% of total daily dose. And if the fasting blood sugar is 110 to 139, add 1 unit. Again, it may varies with the patient. Next is if the patient has hypoglycemia, we should consider discontinuing or reducing sulfonylurea after starting basal insulin, or check any other factors is causing hypoglycemia. So if the blood sugar is less than 70 milligram per deciliter, 10 to 20% reduction of the total daily dose. For example, if the patient is getting 24 units, reduced by 10% is 2 units, reduced by 2 units. And if it is 20%, it reduced by 4.8, which is 5 units, so you reduce it. And then if the blood sugar is less than 40 milligram per deciliter, the guideline says 20 to 40%, which is If it is 24, 20 percentage is 5 units, and then it's a 24, 40 percentage is 9.6, which is 10 units. You have to reduce it. In general, when we starting a basal insulin, the glycemic goal of most patients is less than 70 percentage, and the fasting and pre-meal blood sugar less than 110 milligram per deciliter, and the absence of hypoglycemia. And also in adjusting the A1C and the fasting blood glucose targets, we have to consider patient's age, duration, and presence of any comorbidities. After starting the basal insulin or the long-acting insulin, still the blood sugar or glycemic control is not achieved or not at goal, we can add GLP-1RA or SGLT2 inhibitor or DP4 inhibitor, which we will discuss in another video. I'm planning to do a video on those medications. Then we can add prandial insulin, which I will talk about the second section in the prandial units, which is basal bolus. So begin prandial insulin before each meal. This I found it as a very easy method to remember than get confused with the different methods. So it is the total daily dose we calculate is as 0.3 to 0.5 units per kilogram, and then 50% as basal, and then 50% as prandial. For example, if we calculate the total daily dose for a patient as 12 units, the 50% is basal, which is 6 units will be basal long-acting insulin, and then the 50% is prandial divided into 3 meals, which is 6 units, 2 units prior each meals. Now coming to the first section in the table, it's a basal +1, +2, +3. So what it says is that begin prandial insulin before largest meal, and then if not at goal, progress to injections before 2 or 3 meals. So start at 10% of the basal dose, which is, if it is 24 units, it would be 2 units, or it says 5 units. So that is why I like the second one, the basal bolus, which would be a definitive method, which is 50% of the total daily dose is basal, and then the 50% is divided into 3 meals. Next is how to calculate insulin dose per Diabetic American Association guidelines. You don't have to follow both guidelines, you can follow one of them. So in the most of the patients will be already on metformin or other non-insulin agent. So per American Diabetic Association guidelines, starts with the first 10 units baseline, or initiate 0.1 to 0.2 kilogram per day, which means if a patient with a 60 kilogram body weight, first 0.1 kilogram per day is 6 units, or if it is 0.2 units per kilogram per day is 12 units. Then adjust 2 to 4 units weekly or twice weekly to reach the goal of the fasting blood sugar level. Then for hypoglycemia, determine and address the cause, and if no clear reason for hypoglycemia, decrease the dose by 4 units or 10 to 20%. So next is, if A1C is not controlled, there are 2 ways. One, it's similar to the endocrinology guidelines. Add 1 rapid acting insulin injection before the largest meal, and then or add, if it is still not controlled, add greater than 2 rapid acting insulin injections before meals. And there are also the adjustments for hypoglycemia and the increasing and the adjustment dose for your target goal, or add GLP-1RA, which we discussed with oral hypoglycemics, which I am planning to do a video. Number 3, change to premixed insulin twice daily before breakfast and supper. The dosage of the premixed insulin will be like 2/3 in the AM and 1/3 in the PM, or half dose in the AM and a half dose in the PM. For example, if a patient has to take 20 units, 13 units in the morning and 7 units in the evening, or 10 units in the morning and 10 units in the evening. So, and also the adjustment is the same like a basal insulin, 2 to 4 units once or twice weekly to reach the goal of the fasting blood sugar. Or if it is for hypoglycemia, it's the same. If there is no other clear reason for hypo, decrease the dose by 4 units or 2 to 4 units, like 10 to 20%. We have already discussed insulin comes in vials or pre-filled insulin pens. So as providers, we have to educate the patient how to administer insulin, how to draw the insulin out of the vial. So first step, wash hands with this warm soapy water. And then if using cloudy insulin, NPH or 70-30 or 75-25, roll the bottle between the hands. Number 3, clean rubber stopper of insulin bottle with the alcohol, and then fill syringes with air equal to the number of units of insulin you want to draw from the vial. And then number 5, insert needle into the bottle and push air to the insulin bottle. And then as you see in the picture, turn syringe and bottle upside down and draw out your dose of insulin. Before we go and discuss about the insulin pen administration, let's compare the cost between insulin vial and the pen. As you can see in the picture, the insulin aspart, the first one, 10 ml vial, which has 1000 international units, cost $29.49. 5 into 3 ml disposable pen, which is 1500 international units. That's why it costs $62.25. Because look at the cost per ml, it's $295 and $415. Not much of a big difference. And then the same insulin glueless in 25 and 51, it's double, but it's one is 1000 international units, the other one is 1500. The price difference, $260 per ml, $346 per ml. Then insulin Lispro, $285 per ml, $375 per ml. It's double when you look at the price of the vial, 10 ml vial and 5 into 3 ml vial. And then when we look at long-acting insulin, there is 617 and 619 vial versus disposable pen, not much difference. Then NPH insulin, it looks 23 and 46 for the 10 ml versus 5 into 3 ml, but that is more than the 1000 international units in the pen. So it's $237 and $3 difference. Then pre-mixed insulin, you can see $237 per ml and $3 again. And then Novolin 3070, it's $238 and $3. As clinical providers, nurse practitioners, we all know that nowadays patients use more pens than syringes because of various reasons. They claim accurate dosing, less pain due to smaller needles, and patient adherence is more, time saving, and better quality of life. Next is how to use insulin pen. This is very important for us, our nurse practitioners or clinical providers, because if we have done everything to the patient and the target blood sugar level is not reached, so we can check about if the patient is on other medications or correct techniques are used. So let us discuss the steps. 1, wash your hands and check that the injection site is ready. And then the sites to inject are back of upper arm, stomach or abdomen, and then front and side area of thigh, or back part of the body, which is both buttocks. And the latest recommendation is that use same site but different location, and then switch weekly. Not applicable if there are like a hardening of the site or there is lumps, because the patients can clearly understand which site has how much absorption and understanding their own body. That's what they're telling the reason. Then number 2, if necessary, place a new insulin cartridge in the pen. If mixed insulin or NPH insulin must be well mixed until the entire liquid is cloudy. So roll, if you are using that cloudy type of insulin, generally roll the pen between your hands to mix. Number 3, screw a new needle into the pen. Remove the outer and the inner protective cap. Make sure you keep the outer protective cap. This is needed for the disposal of the needle. Next is we have to make sure that the pen is ready to use. So select 1 to 2 units on the dosage calculator and hold the pen with the needle upward. Tap the side of the pen to allow air bubbles to rise to the top, like every time, and then press the dosage button down and ensure that the insulin comes out at the tip of the needle. If no insulin comes out, then repeat the process again. Now, number 5, you can see in the picture, select the insulin dosage using a dosage selector, and you can see the yellow marking and the black, which is increments. So for example, if it is a Tresiba U100, they have 1 unit increments, but in a U200 they only have increments in 2 units. So that's very important for patients, and they have to be very careful about the units that you have to make sure they know about it. And then next step 6, if necessary, pinch a piece of skin. Modern pens usually have such a short needles that even without pinching a piece of skin, there is no danger of injecting, or it doesn't gonna go to the muscle. Now, next, stick the needle rapidly and vertically into the skin as you see in the picture. Inject the insulin slowly and steadily. Press the dosage button with your thumb as far as it will go and wait 10 seconds until all the insulin has been administered. Put the pen needle straight out of the skin and release the pinched skin. Last step, replace the outer protective cup and use it to remove the pen needle, and so dispose the pen needle in a shatterproof container. Next, what are the side effects of insulin? Hypoglycemia, which is a common one and the dangerous one, and then general weight gain. Number 3, redness at injection site or edema or itching on the site, and then severe allergic reactions, hives, edema, chest tightness, or shortness of breath. Regarding hypoglycemia, we have to check the patient is not on other oral hypoglycemic agent, which has a major side effect of hypoglycemia. All the oral hypoglycemic agents, most of them may have hypoglycemia, but like sulfonylureas, it's we have to make sure the patient is not on that too. Then what are the signs of hypoglycemia? Shivering, as you see in the picture, excessive hunger, cramps, visual impairment, anxiety, drowsiness, outbreak of sweating, palpitation, headache, word retrieval difficulties, vertigo, confusion, character changes, disturbance of consciousness, pallor of the face, nausea, restlessness, nervousness, irritability. Insulin has another side effect of hypokalemia, and also in only a few studies, insulin glargine was associated with increased risk of cancer. Next, we will discuss about the 2 type of hyperglycemia occurrence in the morning, which is called dawn phenomenon or Somogi effect. As the name implies, dawn phenomenon, it's natural, and a Somogi effect, it may be because of the disease management or skipped a meal or something. So, the dawn phenomenon is, as you see in the graph, you can see normal blood sugar in the bedtime, normal overnight, and morning high blood sugar. So it's a physiological phenomenon that causes a rise in blood sugar level in the early morning hours, typically between 2 a.m. and 8 a.m. So during the night, what happens? The body releases hormones such as growth hormone, cortisol, and glucagon. These hormones stimulates the liver to produce glucose, which raises the blood sugar level. So when the blood sugar level rises in people without diabetes, the pancreas releases insulin to counterbalance this increase. But in people with diabetes, the pancreas may not produce enough insulin, or because of the insulin resistance, so there is no insulin. So to counterbalance this increase in blood sugar, so that is why the blood sugar level remains elevated in the morning. So how do you differentiate dawn phenomenon and the Somogi effect? As you see in the graph, in the Somogi, you see normal in the night, and then low blood sugar overnight, and then high blood sugar in the morning. So checking a blood sugar like at 3 a.m., if it is normal or high, it is dawn phenomenon, and if it is low, it is Somogi effect. Again, for the dawn phenomenon, it could be the blood sugar level was normal, and it's normal in the overnight, and then there is high. So what we can do is that there are different options. One is like do the exercise in the morning, or another reason could be that the insulin was taken like very early, not at bedtime, so we can adjust that. Or don't eat carbs before sleep. So in the Somogi, it's, as we say, that it's an effect of something. So it's either because the patient missed the dinner, or the insulin was too much, so there was hypoglycemia. So for the hypoglycemia, the body responded and compensate with the high glucose. That is why the morning there is higher blood glucose. So we can decrease the insulin in the night or have a light snack. Those are the management. So there are different scenarios in which if the blood sugar is normal, because the reason of the hyperglycemia in the morning is because the long acting insulin in the morning may be wean off by the next day. So what we can do is that we can switch it to a like a twice daily long basal insulin, or like we have discussed about Tresiba, 2GO, those kind of insulin which last like ultra long acting insulins. Again, these are all varies from patient to patient. So we need to educate the patients to monitor the blood glucose in the night and in the morning consistently, and in the middle of the night consistently for a period of time, so we can identify the real cause of it. For the nurse practitioner students to remember is, as I say, look at the name, phenomenon, natural, but there was no low blood glucose in the middle. But in the Somogi, it's an effect of either skipped meal or because of the increased insulin. So that is why there is a low hypoglycemia in the middle of the night, and then causes the high blood glucose. So you can remember that way. Next is the insulin pump. We already discussed about how to educate the patients who get the insulin through syringe or insulin through pen. Most of the patients that we meet in the primary care, if they have insulin pump, they would have an endocrinologist on the board. Still, it is good for nurse practitioners in the primary care or nurse practitioner students to know about the difference between different insulin pumps and the technological advancements, and to know which pump is suited for patients if we have to order and we have to monitor it. Basics of insulin pump. Insulin pump is programmed based on patient's insulin needs. Insulin is infused into a fatty tissue through a small plastic tube called a cannula that is attached to a reservoir in the pump. You can see in the first picture. It can continuously deliver basal insulin or do a quick bolus for a carbohydrate intake. There are patients who did a surgical implants for the pump or an iPort, which is through which you can give insulin through the syringe. But normally for the pumps, we don't need to do that. This tube is inserted under the skin by a needle, which is infusion set. It should be changed every 2 to 3 days to prevent infection. And also only rapid acting insulin is used in a pump. All pump can use Humalog or Novolog. But for the Fiasp or the new rapid acting insulins, you should check with each pump's manufacturer leaflet. Since pump delivers insulin continuously, there is no need of long-acting insulin. Which are the patients who uses this? The people who have to take multiple daily injections and check blood sugar several times, and they don't want to deal with it. And also some patients who needed improved diabetes control. The advantage is that there is great flexibility in time of meal and exercise for especially patients who are very active. And also the data can be retrieved and can be used to adjust the care plan by the providers. Very important, we have to make sure the patient cognition is okay, and if the problem solving skills are good, they will be an ideal candidate. Let's review each insulin pump. As primary nurse practitioners, we may not see a lot of insulin pump problems or a different variety of insulin pump, but it's good to listen to what patients reviews about insulin pump or complaints or the endocrinologist reviews. So the first one in the category is the second one in the picture, the pink with the black, that is Medtronic. The sensor is unique to that company. There is a basal adjustment every 2 to 6 days. As you see in the picture, the target is 120 and the correction is fixed at 150. It has a good control of blood sugar, and this was the first one came in the market. So people who are using that, they are continuing to use it. And the advantages the endocrinologist says is that the infusion set has less problem based on their patients. They haven't heard much problems, and the disadvantages are that they have to change sensors and as every week or calibrate. Next is the second row, the first picture, tandem slim insulin pump with the control. There are two versions, basal and control. Control IQ is the latest one in 2020. Basal was in 2018, but they use very good sensors, Dexcom sensors, and their target is 112 to 160, and the correction is fixed at 110. The control has the newest mode called exercise mode, sleep mode, and extended bolus delivery, and update automatically. So this pump says, per endocrinologist reviews, they have the tightest control based on their observations. Next one, the second picture on the second row, iLet Bionic Pancreas System insulin pump. So this is a very simple or user-friendly, any novice can use. Those are the advantages. They have adjustment of basal, adjustment bolus, and the wireless charging is there. But the disadvantage is that they don't have that much of a tight sugar control compared to Tandem or the Medtronic. There is another advantage. They are comparatively cheaper compared to Medtronic or Tandem, which is this one Bionic costs like $4,000, while Tandem and Medtronic is like $7,000 to $8,000. Next is Omnipod. As you see in the picture, it is a non-tube pump. It pops a cannula for you, so very user friendly, especially for elderly and children. And then the patient's review says that it doesn't sting, and it has a handheld unit, but you don't have to carry. It's very water resistant. This is would be the suitable one for patients who have to do and undo the insulin pump frequently. And also the basal adjustment is with every pad change, and the target is at 110 to 150. The correction is flexible, and they have the activity mode too. That's another good feature. Comparing the cost of all pumps, Medtronic and Tandem or T-Slim pumps, they have an upfront cost of $7,000 to $8,000 plus the cost of supplies per month. And also the next one is Bionic. They are cheaper than the other ones. It's like close to $4,000. And then the Omnipod doesn't have that much of an upfront cost, maybe close to $1,000, but there is like every 3 days, $50 you have to do for the changing the Omnipod, which is disposable. So the cost sometimes for the Omnipods exceeds maybe the total cost of the pump, even though their upfront cost is higher. Comparing the cost of different pumps, Medtronic and Tandem or T-Slim, the price is about $7,000 to $8,000 plus cost of supplies every month. Bionic is cheaper than Medtronic and Tandem, price is about $4,000. Omnipods, you don't have to spend for device, but about $50 every 3 days for disposable Omnipods. So this can exceed the total cost of pump on the other side of Medtronic and T-Slim if you don't have insurance coverage. In summary, insulin treatment, whether through pump or pen or syringe, American Diabetic Association recommends HbA1c goal is less than 7% generally. We can individualize goals based on age or life expectancy. In elderly, it is a less than 8%, or goals can be changed based on duration of diabetes or comorbid conditions or CVD or microvascular complications. Next is, as providers, what we can educate patients about insulin. Number one, storage. Insulin at use, keep at room temperature for 28 days only. Do not use insulin that is cloudy or has any sediment or visible changes. And if it's unopened, keep it refrigerated. Number two, Lantus, Glargine and Levomir should not be mixed with other insulin. Number three, when mixing insulin, the clear rapid acting and short acting insulin should be drawn into syringe first. Nowadays, that problem is not much there because patients have usually use mostly premixed insulin. Number four, educate regarding sites of injections, method of injection, side effects, signs of hypoglycemia, which we already discussed. But regarding hypoglycemia, we can discuss the patient's a plan for managing hypoglycemia, discuss about factors cause hypoglycemia, and tell them to monitor the blood glucose regularly and bring to the office the documentation of how is their blood sugar pattern. Number two, teach patients to balance insulin use, carbohydrate intake, and exercise. Instruct patients to carry a source of glucose, such as glucose tablets or lifesavers or raisins with them. Clinically, we should always periodically monitor patients' cognition because then only they can assess their signs of hypoglycemia. Number five, a regular or short-acting insulin should be given 30 minutes prior eating, rapid-acting within the 15 minutes. And disposal of syringes in a resistant disposal container. And number seven, last one, general diabetic education about the food care. For example, a patient with a peripheral neuropathy should wear proper footwear and examine their food daily for any kind of injury or because they may not feel the sensation. So regular checkup of the food and regular eye checkup and therapeutic lifestyle changes and nutritional education, like education regarding low glycemic index food, and if they need further education, refer to a nutritional therapist. And then reduce intake of trans or saturated fat in case of patients who have a cardiovascular risk. Our goal should be LDL should be less than 100, and the intake of alcohol should be 1 drink per day for women or 2 drinks for men, and a physical activity about 150 minutes per weekly. And also, if they have they are planning for exercise and the pre-exercise glucose is less than 100, recommend adding carb. In this video, I'm only talking about the insulin and the different type of insulin and the administrations, not general about the diabetes, but a word about diabetic referral and follow-up. Regarding diabetic nephropathy, achieving normoglycemia and lowering blood sugar have proven to delay the progression of the disease. So consider referral to a nephrologist for patients with advanced kidney disease, but we can prescribe patients on ACE inhibitor or ARB and monitor serum creatinine and potassium levels. Diabetic retinopathy, consult an ophthalmologist, and if we are suspecting any peripheral vascular disease, do a vascular consultation. And then if the patient is currently smoking or any lower extremity complications, do a foot specialist consultations. Regarding follow-up, when the patients are making major change in the insulin program, advise them daily blood sugar documentation and frequent contacting with the healthcare team, especially until the risk of hypoglycemia is low. And regarding regular follow-up, patients should be seen every 3 months and then decrease to 6 months when stable. I'm concluding this video of insulin and type 2 diabetes mellitus. Here earlier. We discussed so far type 1 and type 2 diabetes difference, insulin different types and mode of action, how to calculate insulin dose, how to educate patients regarding the administration of insulin from vial or pen, cost comparison, side effects of insulin and signs of hypoglycemia, Dawn phenomenon or Somogi effect, in different type of insulin pumps and comparison, and a patient education about insulin storage or diabetes referral and follow-up. Hey, thank you for watching my video.